Good afternoon, ladies and gentlemen. I'll have some guilt feeling somewhere that I am depriving you of the lunch opportunity, but I hope you will bear with me. Thank you, Chetna, and thank you, AHPE, for bestowing this honor on me. And I'll try to share my thoughts on implementation of competency-based medical education in next 35 minutes or so. But before I start, I just want to caution you that whatever I am going to say is in the context of CBME as a concept. So please don't start comparing it with our curriculum, local curriculum, etc., because it is not really directed at that. It is about the concept of CBME. And I agree with Janet that you have to have a local truth. So what we talk about is, thank you. And the second thing, I want to make a disclaimer right in the beginning. Don't compare my design with Jenner's. This is purely incidental and unintentional. Now, whenever I read or talk about competency-based medical education, in fact, the word which comes to my mind is Shastrarth. And just for Ara and Janet, who may not be aware of this terminology, Shastrarth is a type of intellectual debate which happens between educated people to derive a meaning out of the holy scriptures. Because there is no right or a wrong answer, and it all depends on what way you explain it, what way you argue, what way you reason it out. And competency-based medical education, to a large extent, to me at least, looks like a Shastrarth. Because each one is trying to explain the concept on his or her own understanding, philosophy, values, approach, and so many other things. Few years ago, I came across this quote, I don't know the author, that medicine and medical education, like women's shoe, are governed by dictates of fashion. And I suppose it is largely true, because having seen the turn of events over so many years, you can identify with this. Let me elaborate a bit more on that. So if you look at the 18th century, a competent doctor was the one who carried a blade and who carried some emetics and some laxatives, who would let out your blood, give you those drugs to purify your system. Maybe another century later, competence came to be seen as a person who can make a diagnosis by looking at the tongue, feeling the pulse, and smelling the urine and stool. In fact, in our country, it even went a step further, that he could diagnose pregnancy by, but that's a different story. And in the 20th century, competency was like discussing a woman's health with her husband, but withholding the diagnosis so as not to generate anxiety. What is considered competent today will not be considered competent another 10, 20, 50 years later. And what is competent today was not considered competent, say 50 or 100 years ago. And with this came the Flexner report, which categorically equated competence with knowledge, and especially the knowledge of basic sciences, so that the students know enough of basic sciences before they go on to learn the clinical medicine. And assessment focused exactly on that, what they knew. So in a sense, competence and knowledge were considered almost similar. With the advent of the competency era, more roles started to be given for the patient's perspectives, and the focus of competence actually shifted from knows to does. Greater emphasis was placed on skills, and then around that time came Miller's pyramid, which apparently put performance at a higher level as compared to knowledge. Now, I'm not sure if this was intentional or it just happened. I can make a hazardous guess that more than half of the people sitting in this audience have not read the original paper of Miller. I spent 7 days reading this paper over and over and over again. I discussed it with 3 of my colleagues who are experts, who are quote and unquote experts in medical education. And what is interesting actually is that Miller has used the term pyramid only once in this paper. Rest of the times, he has used the word triangle. So, pyramid signifies a hierarchical structure, but triangle doesn't. You can see one triangle which is here, and you can actually see another triangle here. And next page is also again 2 times he has used the word triangle. So I'll revert to this a bit later. Now I want to bring to you the power of narratives. You know, narratives have a very strong influence on the way we believe, on the way we act, on the way we perceive. And especially in this era of IT, easy availability of information, easy dissemination of information, narratives become very important. If you look at clinical medicine, we have seen these. When I was a 3rd year student, in our town there was a hepatitis A outbreak, and the recommendation was, WHO recommendation was, go and get 1 cc of immunoglobulin shot. 78 I'm talking. And then we as students, would go and line up at 6 a.m. like now people used to do for COVID vaccination. And by the time your turn came, the injections were over. So next day again, the whole process started. Something similar we have seen with vitamin A, we have seen with statins, with vitamin D, with zinc. They came, they stayed for some time, they went away. Again, made a reappearance, again stayed for some time, again went away. And same thing seems to happen in the field of medical education. We have seen PBL coming. I remember 10 years ago or 15 years ago, when even there was no regulatory pressure, Medical Council of India was not even talking of PBL, but still every college in the country was dying to have a PBL. Now, like I am called for talking about assessment and other things, that time the only invitation was for PBL. To come and conduct a workshop on PBL. We have seen clinical audits, we have seen educational audits, we have seen evidence-based medical education coming and going, and then from behaviorist to cognitivist to back to behaviorist and so on. Now, one point of view which Harden wrote in Medical Teacher 2007, he says that CBME is an intuitive approach that engages the range of stakeholders. It encourages a student-centered approach and at the same time supports the trend for greater accountability and quality assurance. Makes sense? Intuitively, makes sense. David Cook, around the same time, he says that adoption of outcome-based education would equip the medical graduates to respond effectively in complex situations and efficiently continue to expand the depth and breadth of the requisite competencies. Please notice the prediction. It will expand the depth and breadth. So, when we were struggling with learning objectives after Meagher became a hit, we realized that our graduates are not able to integrate the knowledge, skills, attitudes related to patient care, and so we must bring them together. So one type of integration that we see, horizontal, vertical, that is a separate issue. But what I am talking now is integration of the knowledge, skills, attitudes, professionalism, ethics, and so on. And so we created competencies, which you saw the definition. It's a combination of knowledge, skills, attitudes, etc., for the welfare of the patient. But when the time to teach comes, we again break the competencies into learning objectives. And if you look at some of the recent papers from very good institutions, from people who are considered experts in competency-based medical education, it has been said that this is perfectly justified. There is absolutely no issue with it. Okay, we'll take that point. Now, maybe calling this old wine in a new bottle would have been rude. So, people actually coined the term reconstituted behaviorism. Because basically, competency-based medical education was actually a combination of learning objectives which we were following from the time of Meagher. And around the same time, a different set of views emerged. And now you know why I asked you not to compare my clothes with Janet's clothing, because this is what Janet wrote in the year 2000, that what you do as a clinician is far greater than any of the parts that can be described in the competence terms. And she very rightly puts, the greater your expertise, the greater your individuality. If everybody was doing the same thing, then where is the expertise? So experts have to be doing something more, something different, something with a different perspective. Yet another perspective came that competency models have questionable outcomes in terms of professional understanding and professional performance. And you can see the contrast. Harden and Cook, they talk about CBME helping the graduates to provide a better quality of health services. Here we have somebody saying that it has a questionable efficacy in terms of understanding and professional performance. More importantly, competency is not the same as competence. So discrete collection of competencies doesn't make you competent. That's something which needs to be kept in mind, and you may be wondering who wrote it. Talbot, who wrote it in 2004, actually coined the phrase monkey see, monkey do. And I was kind of not surprised that when you live in an era full of iPhones and iPads and iMacs and iPills, then it was actually a bit strange that somebody wouldn't have thought of a iDoc 2024 Ultra Pro Max. Another viewpoint, and look at it from the perspective of again what Harden and Cook had written, that curriculum designer controls the activity of the teacher, and teacher controls the learning environment of the student, creating a power differential. Teachers have no control over curriculum, students have no control over learning, and both are being disempowered. Coming back to Janet once again. In the meanwhile, I leave you to ponder the question of why we are prepared to adopt a practice, even the definition of which we have not really agreed. And I'm sure when Janet wrote it, it was not just coming out of the blue. It was based on sound theoretical argument, the Shastrarth, or the intellectual debate that we say. And McGagey, when he wrote for WHO about outcome-based education in 1978, that was the time when he himself wrote that it would be pointless to suggest that there would be a single definition of a competency-based program. So it started like that there is no fixed definition, and you can have multiple versions, multiple definitions, and other things. And later, Frank and Associates, 2010, on behalf of international CBME collaborators, did a systematic review. And they found that there are a large number of publications heavily weighted to models and commentaries. So if you look at the findings of their systematic review, then you find there were 165 different kinds of organizing frameworks, 53 rational, 35 contrast with time-based education, and 20 implementation. So, as I said, that competence was associated with knowledge. But then it was perceived that our graduates lack the skill. In fact, one senior functionary from one of the ministries, once he was talking to me about this thing, and he told me that your graduates don't even have the skill of writing a prescription. So this plus many other perceptions about lack of skills probably became the driver of change, with more emphasis on skills. And again, viewing Miller's pyramid as being hierarchical, with does at a higher level compared to knows, contributed to this. And this focus on skill assessment actually impacted student learning. Fair enough, if somebody says that students would learn more skills if you assess more skills in the examination, I think that was a positive effect of assessment, and there was nothing wrong in that. So competence seemed to be equated with performance. But what is interesting is, and I'm quoting Jeff Norman, that knowledge is not so down and performance not so up. In fact, he uses the phrase that cracks have actually started appearing in interpretation of the Miller's pyramid. We all have seen this. Can keep doing a lot of things without knowing. We all use computers. We all make slides. We all type on Word document, but we don't know what is actually happening inside the computer. Look at your operation theater assistants. Look at your dialysis technicians. Look at your anesthesia assistants. They can do a lot of things correctly, but without knowing what they are actually doing. Look at quacks. They do so many things which even our graduate doctors are not able to do, but without knowing what they are doing. So you can keep on doing a lot of things without actually knowing about the basis of why you are doing that. And Eva commented that you have to have relevant knowledge for problem solving and decision making. And that is interesting. Even Lambert Schubert and van der Lutten say that problem solving and decision making doesn't exist as a separate construct away from knowledge. Unless you have knowledge, you cannot have problem solving. You cannot have decision making. And they emphasized on the interdependence of knowledge and skills. Norman again states that diagnostic reasoning is the first step in treating, and it depends on knowledge. Now, independent of what Norman says, I personally strongly believe that the starting point of any competence is making a correct diagnosis. If your diagnosis is wrong, no amount of skill, communication, ethics, professionalism, etc., is going to help the patient. And if you look at the origin of the word diagnosis, it's a Latin verb, which dia means through and gnosis means knowledge. So what you do through knowledge. So that is actually diagnosis. We have also, I just quoted one, but we have had multiple reports. In fact, if you Google, you'll find more than 100 papers to say that OSCE scores don't align with diagnostic reasoning. You'll also find plenty of reports to say that OSCEs don't discriminate between experts and non-experts. In fact, it is sometimes other way around. Experts are known to score lower in OSCE because they use other things like intuitive things and concept maps and mind maps and scripts and so many other shortcuts to diagnosis. And then I found this paper from one of my former batchmates, Rashmi would remember, Seki. What he found out that the graduates passed all the skills that were listed, but the pass rate on MCQ test related to knowledge of that skills was only 35% or 39%. So actually this takes the sheen out of the argument that if you move up the pyramid, your competency level will improve. It probably doesn't happen that way. And even otherwise, when you lay more emphasis on assessment of practical skills, then it could lead to poorly integrated knowledge and fake performances. I was called by a National Board of Examination to act as a examiner for DNB, and you might be aware that pediatrics is one of the disciplines where they use OSCE. I think another is ENT or ophthalmology, two of these. Now, I was allotted a station on communication, and I could of course see what is happening on the stations which were on my side. And on the communication station, each student, whenever he entered the place, he would start out, Namaste ji, mera naam ye hai, main aapke bacche ke saath aise karunga. Fine. But at the next station, nothing. And if you use overemphasis on simulation or wrongly use simulation, then you can produce what is called simulation doctors, who can act out good relations with the patient, but who actually don't have good relations with the patient. This morning somebody, I don't know who told Avinash, I think Dr. Gulati had said that AI is no intelligence for natural intelligence. I would like to modify it to a bit, that AI is no replacement for natural stupidity. And then came the era, and then came the thought that competence should be equated with the test scores. That is the best thing to do. You have a student, give him CBME, examine him at the end, the entry exam, the exit exam, and then you would know whether it has worked or it has not worked. And from Barrow's time, when this concept of SPs came, that emphasis on standardized tests and standardized patients actually started. And in the process, we left the measures of good doctoring because of the psychometric skepticism. If you cannot assess anything objectively, just leave it. The McNamara fallacy. But what actually students do is to focus on behaviors that will improve the hits on the checklist. And this I can tell you from real practical experience of having conducted OSCE in pediatrics for at least 20 years, that you cannot keep a checklist secret for more than 2 to 3 iterations, after which it is known. We made a checklist on development history of a child. So initially they would struggle, chala kab tha, baitha kab tha, variety. But then after 3 or 4, suddenly when they learn, soya kab tha, chala kab tha, khada kab tha, utha kab tha, khaya kab tha, they know the checklist already. So you have changed the construct. You are remembering their memory. You are not actually testing their clinical skills. And teachers would also resort to what is called teaching to the test. See, all these OSCEs that people make for their own departments also end up getting published in the form of some book, some blog, some website somewhere, to which the students have access. And it actually pains me to see the market being flooded with books where on one side they have listed the competency, on the other side they have listed the answer to that competency. Now recall what David Cook said, that it will increase the breadth and depth of students' knowledge. Probably it doesn't happen because it becomes more focused. What is written, they would learn that. And I am not at all talking about the coaching classes and private tuitions that the students engage in. I believe from second year onwards, they actually start joining the coaching classes to score better in the PG selection examination. Now, knowing that there are issues, and this was not particularly related to CBME, for education in general, that there are issues about high-stake assessments. So, van der Lunden came out with the concept of programmatic assessment. where the stakes were deliberately kept low so that it will not pose a stress on the student, and a lot of feedback could be provided to the student to improve their learning. But whatever said and done, two things needed to be kept in mind. One, that low stake does not mean no stake. Low is also a stake. And second, and that is interesting, unfortunately the students knew that it is going to be used for submitting. So that whole purpose was somewhere lost. And if you look at it this way, I was once discussing this concept with Rashmi Kusurkar. She is in Netherlands, many of you might know her. She told me, sir, programmatic assessment works only in Maastricht, nowhere else. I don't know what is the current status of programmatic assessment, but in its classical form, I don't think many institutions or many universities have been able to adopt it. And then problem comes when you use the same assessment for more than one purpose. If you are using the same assessment for certification and the same assessment for selection, then you are inviting, I think trouble is too small a word, you are inviting disaster. And Norsini, very recently, 2023, he says that assessment with more than one purpose is neither optimal nor efficient. Promoting competence in a norm-referenced world is anyway a problem. You know, all of us have been brainwashed, so to say, right from our childhood, that if somebody has got 51 marks, he is more intelligent than you because you got only 50. Now, in that situation, expecting that people will not look at marks is something which is naive, to say the least. And actually what happens, again from the American Association of Medical Colleges, Ryan et al., they developed this graph that if you have strict norm referencing, which you do for selection test, then actually very few people are able to cross the competency threshold. But still what is happening here is that B has got more marks than A. And presuming that there is only one seat, B would still get selected in spite of not meeting the competency threshold. And if you add strict mastery learning or competency-based threshold, then, and that is what actually you want. You don't want more students on this side of the graph. In a competency-based curriculum, I want every student in my class to be able to answer those questions correctly and be on this side. And now here what is happening, that C and D, two students, they have actually crossed competency threshold, but there is a difference in C and D, and this creates a artificial comparison between the level of competence of two students. So either way this can create a problem. Norsini suggests that if you have one exam for two purposes, you might have thought that you are actually saving on one examination, but in effect actually you are wasting one examination. Then there are other issues related to competency-based assessment. Each assessment, each competency has to be measured with multiple instruments. As I said, none of them exists as a pure construct. To be a clinician, you need to be a professional. To be a professional, you need to be a clinician. To be a clinician, you need to be a communicator. To be a communicator, you need to be a professional. To be a professional, you need to be a communicator, and so on. So if you don't have pure constructs, then you need to have multiple tools for assessing competencies. But what is more important is that pass criteria needs to be set at the competency level rather than at the domain level. So it makes little sense to say pass in theory or fail in practical. That makes no sense, because again the very premise why it started was that students are not able to integrate knowledge and skills. So if you are separately passing them on practical and theory, then you are actually defying the whole thing. And then there is a lot of qualitative information and narratives which come into assessing competence. And thank you, Ara. This morning I discussed with him about his paper that he wrote with the Canadian group, that converting these marks or converting these narratives into marks will actually be reductionist. You'll be losing a lot of information. And even if you were to do, how do you combine the marks of OSCE with multi-source feedback? You cannot do that. You cannot take a simple mean and put it up over there saying that you have passed or you have not passed. So these are some of the issues. And I want to bring you to one of the very important concepts. In fact, it really caught my attention. And that is the concept of degree of freedom. We know that it's a statistical concept, but Glaeto and colleagues in 2016, they came out with this, that if we want our assessments to reflect our values and social priorities, we need to break free of the self-imposed constraints of using medical college admission test and USMLE scores to determine who advances into medical school and residency. As long as you will have a USMLE, for the students that will be first priority. If in the Indian context I say, as long as you have a NEET, for the students, that is the first priority. They are not interested in learning about professionalism, and that's what we heard Janet tell yesterday, that if it is a course material, okay, we'll pass and move on. So it becomes like that. When you have an entry test, that it becomes the priority. And as you know, degree of freedom, that in a triangle, for example, the sum total of all angles can be 180. So it means you can only vary 2 angles. The third will be automatically decided because the sum total has to be 180. Now you can do little variation, presuming that each angle is 60, you can make one angle 75 or maybe 90. Okay, you still have margin to manipulate the other angle. But if you make assessment as say 120 or 130, then all your degree of freedom is gone. And lastly, the current discourse, in fact, projects competency-based medical education as infallible. It serves 2 purposes. One, that it buffers CBME against any negative appraisal. And even if you don't want to believe me, please Google any paper on competency-based medical education and read it. It will put 2 things. One, that your interpretation is wrong, you have not understood what CBME is. And since you have not understood what CBME is, your implementation is wrong. So the buck actually stops with you, not with CBME. And interestingly, this discourse on infallibility of CBME also controls what is funded, what is researched, what is published, and what is said. This was a critical discourse analysis of papers published from 1996, that is the year when CanMed's competencies came into bearing, till 2016. And let's look at some more aspects from this study. So most of the issues, they actually centered around implementation and interpretation. And there has been a discursive response to critiques. Discursive response means something which goes against the dominant response. What is interesting is people who are critiquing CBME cite on an average 6 to 10 references which come out of theories of learning, sociology, psychology, philosophy, and medicine. People who defend CBME cite references which come from position papers, perspectives, opinions, and the likewise. So much so that claimed benefits actually become accepted truth. But so much it has been ingrained in our mind that when you read somewhere that CBME will produce better self-directed learners, you don't ask, sir, where is the reference? Where is the evidence? Nobody asks. And even where the references are provided, again, as I said, they are from one reference starting, which keeps on cycling, recycling, without any empirical evidence actually being produced. And this is what Boyd and colleagues had to say about this discourse analysis, that the dividing practices that shape what can and what cannot be said about CBME also inform who can and who cannot say it. I was, honestly speaking, I was very scared of making this presentation in front of this audience. Till this morning I saw Janet in the same design, so that gave me some strength to say it. They further say that those whose opinion aligns with the dominant discourse are accorded legitimacy, whereas other voices are suppressed. You tell me which journal will publish your paper if you say CBME is not good? Which conference will accept your paper for? Fortunately, they didn't have an opportunity to screen my presentation. Otherwise, they would have turned it down. No, sorry. And over time, these power structures become normalized in medical education, and benefits of CBME are now so taken for granted that they don't require any reference or any source to corroborate them. But the bottom line is CBME has arrived, and arrived in full swing. So, Norman, Norsini and Bordage, they said CBME will be adopted despite its distractors. This was in 2014. We are seeing in 2024 it has been adopted. So what do we do now? I suppose the best course would be that rather than trying to find meaning and trying to find interpretation and implementation, we actually look for strategies to make best use of it. I think that is the best thing we can do at this moment. And one of the things which we need to be careful about is what are the essentials of a good CBME curriculum. I mean, please understand it in that perspective, that you really can't change it now. You can't undo it now. And essentials of a good competency-based curriculum include: 1, a clear statement of competencies, which becomes an essential foundation for developing a competency-based assessment. And then assessment strategies to find if these are being done consistently and providing effective feedback to the student. I am tempted to share with you the story of Vishwakarma. As you know, Vishwakarma was the son of Lord Brahma, and he was a divine engineer and architect. One day he was contacted by a very powerful king who wanted Vishwakarma to design a palace for him. So Vishwakarma took it as a challenge, and using all the skills and knowledge and expertise at his disposal, he designed the palace for the king. Somehow the king didn't like the palace, so they had to raise it, and then again he got onto the job and designed another palace, which again unfortunately was not liked by the king. And this happened many times. He would build something, king would not like it, he would raise it, again make it, and this cycle kept on going for multiple iterations. One day while Vishwakarma was meditating, he had an epiphany. He realized that till now he is only showcasing his skills, rather than doing something which will make people joyful and happy. Now with this newfound understanding, he went back to the king and asked him to describe his vision of what kind of palace he wants. So the king described, Vishkarma listened patiently to whatever ideas the king had, and then finally designed a palace with which king was very happy. He said, this is something which is exceptional, extraordinary. Nobody else in the world has this kind of a abode, and I'm happy you did this for me. Vishkarma smiled because he knew that this time he didn't really try to showcase his skill, he only tried to make his client happy and joyful. The story idea was by my colleague Dr. Nilima Shah. Let's put the student in place of Vishkarma and patient in place of king. The patient is not interested what and how many skills you have, whether you received A or B or C or whatever. Patient is not interested. He is interested that this doctor should take care of my problems. He should make me happy. That is what the patient wants. And I suppose the day we start looking at the medicine's forgotten man, you guessed it right, the patient, we would say competency-based medical education has really served its purpose. The calls have already been made. American Association of Medical Colleges talks of patient-centered teaching and learning. Norsini has given a call for patient-centered assessments. So it's for us now to see how many concepts out of these we can adopt in our situation and make CBME useful for us. Before I conclude, since Dr. Gulati started that Shero Shari business, so I thought I'll also do that. Manzil mil hi jayegi, भटकते हुए ही सही, शिकवा तो वो करें जो घर से निकले ही नहीं. I mean, ultimately, you will reach your destination, even if it is taking long circuitous routes. People who have not even come out of their houses, it is they should be complaining, rather than us who have to take a long walk to reach their destination. So thank you very much.